So our presenter tonight is Gil Park. Han is a nurse practitioner at the Howard Cohen NPH Program at Toronto Western Hospital under the Division of Neurology. He has completed his Master of Nursing Primary Healthcare Nurse Practitioner Program at the University of Windsor. He is dedicated to patient education and mentoring future healthcare professionals. Han, thank you so much for joining us tonight, and the floor is yours.
Thank you. Before I begin, I wanted to thank everyone for joining me tonight, and thank you, Dr. Fazano, Dr. Tangway, and Shauna from Hydrocephalus Canada for providing me the opportunity and to discuss about my um, knowledge about NPH and my passion here. So let me know if you can hear me well. So we'll talk about normal pressure hydrocephalus today. My name is Han, as Shauna explained. So today's session we will be discussing about what the normal pressure hydrocephalus is, what are the symptoms, what are the things that are required to make the diagnosis, why the diagnosis is very challenging, what are the treatment options, how does the shunt works, how does the care pathway that works at our specific program at Toronto Western Hospital, and my role as a nurse practitioner in the NPH program. So we'll first define what hydrocephalus is. As many of you guys already know, hydrocephalus is a clinical condition of increased cerebrospinal fluid content within the cranial vault caused by a variety of circumstances. In more simpler terms, it means there's just extra water in the brain. There's two different categories to hydrocephalus. There's obstructive and communicating. Obstructive means there is a mass, can be due to congenital cause or it can be due to secondary causes that blocks the pathway of whether the water flows in the brain, causing the waters to accumulate within the brain ventricles and causing the symptoms. Communicating hydrocephalus means there is a pathway is intact. However, there's a small accumulation of water over time due to the mismatch because of many different variety reasons. So there's the pathway is still intact, but water keep accumulates, causing the symptoms due to these problems. Um, Normal pressure hydrocephalus is a form of communicating hydrocephalus without causing substantially increasing cerebrospinal fluid pressure, meaning that the pressure is within the normal range. However, it's still in the higher end of the normal. Patients with normal pressure hydrocephalus commonly present with problem with the walking and balance, problem with the urinary symptoms, and also cognitive symptoms. The key point to normal pressure hydrocephalus that distinguished from other form of hydrocephalus is that symptoms develop and progress over the years. In some cases, we're looking at 2 to 3 years. Some cases, we're looking at 5, 6 years. So in general, it takes very long time to develop the symptoms. Um, so what are the symptoms of normal pressure hydrocephalus? As we discussed, there's three main symptoms: problem with the walking and balance, problem with the urinary symptoms, and problem of thinking process. In walking problem, we're looking at particular like broad-based gait, slow and small shuffling steps, freezing of gait, meaning your foot are glued to the floor, have difficulty lifting them up, outwardly rotated feet, lack of response to sensory cueing. So these resemble, we often say, lower body Parkinsonism. In urinary control decline symptoms, we're looking at frequency, meaning patients have to go to washroom every 2 hours or more often. Urgency, incontinence. Sometimes the incontinence, not just urinary, they often have, some patients can have fecal incontinence as well. And they can also have nocturia, meaning they need to wake up in the nighttime to go to washroom to urinate. These symptoms are also called overactive bladder. And in terms of cognitive decline, the common symptoms you're looking at are psychomotor slowing, decreased fine motor speed and accuracy, difficulty dividing or maintaining attention, impaired recall, so like short-term memory related issues, executive dysfunction, behavior personality changes, typically more like because of walking and there's other problem that makes the quality of life more difficult. Patients can be easily mad at things because of things that they're not able to do because of problem with the walking and cognitions and such a things. These are the symptoms of this executive predominant cognitive decline. The key point to normal pressure hydrocephalus, in a true normal pressure hydrocephalus form, gait always has problems first, and then urinary symptoms and cognitive symptoms develop later. If someone has, we are suspecting to have normal pressure hydrocephalus, and the urinary symptoms and cognitive symptoms started before the walking problem, we often start questioning, is there any other disease that's mimicking the symptoms of NPH? Is there other process going on that's mimicking the symptoms of NPH? Normal pressure hydrocephalus is a subcortical disorder involving cortical basal ganglia thalamus circuitry. The pathway runs close to the ventricles. Therefore, enlargement of the ventricle when there's extra water in the ventricle disturb the pathway. To simplify all these medical terms, I posted a picture on your right-hand side. That's the brain that's cut into this ways. I don't know if you can see my face. And the different colors means area that's of the brain that's in charge of the particular functions. So the blue shows executive functions like cognitive related functions. Yellow is a micturition, so urinary related functions. Orange represents the gait pathway, so your walking and balance problems. And green shows the behavior related functions that's in charge of the brain. The red is usually where the extra water sits in the ventricles and putting pressure against the brain tissues. So if you can see the red arrows in the three of the red arrows, that's where the water is putting pressure against the brain, causing the symptoms of problem with the gait, urination, thinking, and some apathy and mood related problems. That's how kind of the disease work. So what is required to make the diagnosis? So first, the patient needs to have enlarged ventricle and other radiographical findings of normal pressure hydrocephalus. So there are particular things that we look at in your imaging, like CT and MRI of the brain, such as enlarged ventricles, acute callosal angles, positive Evans index, parietal crowding, DASH, and these are the things that we suspect you may have normal pressure hydrocephalus. Also, you must have some of these symptoms of walking problems, problem with your urinations, and problem with your thinking process. Once you have these two categories, we can tell you that, you know what, we're suspecting that you have possible normal pressure hydrocephalus. So we can safely tell you, you know what, I think we can move on to the next step of the process to see whether we can help you with this or not. So we require cognitive testing, usually by the cognitive behavior neurologist, especially at our site, Dr. Tang Wei and Dr. Dimao, who's the one who conduct these tests, and also lumbar puncture and formal gait assessment. So lumbar puncture, in this case, we remove 40 cc of water from your brain through your lower spine. So the idea is that by removing the extra water that's sitting in your brain, we're trying to relieve a little bit of pressure that's going against the brain tissues, and see if your brain can try to improve the symptoms of your walking, urinations, and thinking process. So the lumbar puncture is a required step for us to determine whether we can help you with the surgical intervention. So the gait analysis part, we do it before the tap test and after the tap test, so we can see not just subjectively, but also objectively see if there's an improvement in your walking as well. So different centers may have different protocols for their gait analysis. For our center specifically, we do before and after at 3 hours mark. So 3 hours improvement is often good enough for us to see if there's any improvement in your walking. And 24 and 48 hours improvement, we often see them from the video we receive from patients. So if there's any improvement in the first 3 hours, we expect the improvement to peak at 48 hours mark up to about 72 hours. So we'll see further improvement as the time goes by for the next day and two. Depending on the center, some centers may do time up and go, 10-meter walk test, 3-minute walk test. There are different ways to assess your gait with the tap test, but our center specifically, we use computerized aided gait analysis before and 3 hours after the tap test with computerized gait met. So it helps us to determine surgical decision based on also both subjective and objective data. And we're able to do this because we have the gate mat and the gate room, as you can see on the picture on the right, and also social scientists and specialized medical team who is able to interpret the data as well. So why is the making diagnosis of NPH very difficult? So these are lists of the disease that may mimic NPH. So NPH with other comorbidities, Parkinsonism, Lewy body dementia, cortical basal degeneration, PSP, multiple system atrophy, vascular dementia, neurocephalus, medication side effects, and multifactorial stuff plus and minus IMPH. Meaning all these diseases, our syndromes can have every single problems of walking problem, urinary problem, and also cognitive problems. And these are more common conditions that we see more often as our body gets older. There's problem with arthritis, Alzheimer's disease, frontotemporal dementia, a problem with the urinary symptoms, pelvic floor abnormalities, cervical stenosis. So a combination of any of these diseases can mimic the symptoms of NPH. Some of them have both gait and urinary problems. Some of them only have gait problem, but if someone also have some cognitive problems, it becomes challenging for even experienced healthcare providers to diagnose these. So the key point here is that there are a lot of disorders that mimic NPH. Our job as a clinician at the Normal Pressure Hydrocephalus program is to see how much of your symptoms that you have right now is to determine whether they come from other disease process versus normal pressure hydrocephalus. If majority of your symptoms come from NPH, then we are potentially able to help you with surgical intervention, which we will be talking about next slides. And that's basically the key things that we do in our Center for the Assessment. So how do we help the patients with normal pressure hydrocephalus? There's two big category, basically shunting options and endoscopy third ventriculostomy. And in terms of shunting options, the VP shunt is the ventricular peritoneal shunt. Basically, we have a catheter in the brain that's connected to the peritoneal space in your abdomen to continuously drain the extra water to relieve the symptoms. Endoscopic third ventriculostomy is more designed for patients that we have for the aqueductal stenosis, meaning they have different form of hydrocephalus with narrowing of certain pathway called aqueductal pathway. So there's extra water builds up because of that. So once we do the tap test and there's a significant improvement and we decide to go for a shunt, we can somewhat safely tell you there's going to be a significant improvement in gait velocity. And there's going to be potential improvement in urinary and cognitive functions. As the disease first develops with the gait problem and then later becomes urinary and cognitive problems, similar when we do treatments, walking usually improves first, and urinary and cognition take time. And cognitions, we often see at least 6 months to 12 months to see some improvement if there's an improvement. I would like to also discuss how the BP shunt works in normal pressure hydrocephalus patient populations. The shunt works in a way that the excess cerebrospinal fluid is drained into the abdominal cavity via ventricular catheter. The clinicians ourselves adjust the programmable valve to control the amount of water we drain. The entire system is under the skin and is not visible, except for the small bump behind. Depends on where the valve is located. At least for our program, we place them behind the right ear. You can see a small bump about the size of fingertip of your thumb. also softer touch, stays at there. Um, if you look at the picture on the left, that's how the VP shunt system looks like in a person. And if you look at the top right, the picture shows that that's the programmable valve that goes under the skin. And if you look at the bottom right picture, it demonstrates how the shunt valve is adjusted. And we'll talk about that a little bit more, how we adjust them, and what's the mechanism that we use. So we'll discuss a little bit more about how our program manages patients with normal pressure hydrocephalus. These may be somewhat similar to other centers, but other centers also approach a little bit differently. But I wanted to give an idea of how we manage at our center. First, when the patient is suspected NPH, we receive referral from family doctors, neurologists, neurosurgeons, and any other providers. We first assess them in the cognitive neurology and movement disorder specialist. So cognitive neurology for us is Dr. Tangwei and Dr. Dimao, and movement disorder specialist, Dr. Alfonso Fasano. And we conduct a tap test, meaning we do the lumbar puncture, removing 40 cc of water, and we do the gait analysis before and 3 hours after. And then we'll have some idea of whether there was improvement within that 3 hours or not. We send the patient home, and then we ask them to simulate how we walked in the center at home so we can watch the video at 24-hour mark and 48 hours mark. As I described earlier, if there's improvement from the tap test, your walking will continue to improve 24 and 48 hours mark. It will usually peak around 48 hours, and the improvement may last up to 72 hours. If there is a significant enough evidence that there's an improvement in your gait, our team will refer to our neurosurgery colleagues for VP shunt or ETV. Most of the patients receive VPS for NPH. And it takes about 3 to 4 months for our patients to go through surgery. Once the patient is here for the surgery, they stay usually 2 to 3 days. And the shunt is going to be inserted at the closed setting, meaning that the water doesn't really drain much extra. It's still slightly open, but the idea is that we don't see much of an improvement the first 2 months. The reason we do that is we want to make sure that the valve, the whole system sits really nicely in our body, make sure there's no complications before we start programming the device. At 2 months mark, our team works very closely with the neurosurgery team to make sure that we see them at exactly at 2 months mark. We start with the initial programming sessions at movement disorder clinic, meaning we slowly open up the valve. And every time we make an adjustment, we do 2 to 3 months intervals, and we do a CT scan at 4 to 5 weeks marked on each valve adjustments to make sure that we monitor any adverse effects and we can intervene early on if there's any problems. Once the patient's shunt is optimized, which takes about 6 months, then we start introducing physical therapy to see a further improvement. The reason we do that is the more we open up does not necessarily mean there's going to be further improvement in your walking, urinary symptoms, and also thinking process. At some point, the shunt effect will plateau, meaning we opening up the valve more at that point may increase more risk of adverse effects rather than the benefit. So at that point, doing a physical therapy, extensive physical therapy can help making up the differences. And we've seen those results in daily basis in our clinic. Once patient is stable, there's good enough improvement, we will follow them every 6 to 12 months in both movement disorder and cognitive neurology clinic. The million-dollar question is, so what happens to the patient who does not have significant enough improvement in the tap test, and how do we go from there? So we can categorize the patients into 3 big categories, although each cases are discussed case by case for follow-up plans and discharge because everyone's different. The first category will be if the disease process is very early on, meaning your symptoms are too mild, it may not show significant enough improvement in our test. In those patient population, we'll often follow and then repeat the tap tests in about a year or so. the other category of patients that are the disease process is already very advanced. So there's not a lot of um, brain that we can recover because there's too much irreversible damage has done to the brain tissue already. In these cases, um, not just that there's not enough improvement from the TAP test, um, recommending the shunt would be too much of a risk versus the benefit. So in these cases, we usually do not recommend having the shunt insertion. The other category of the patients are um, there are patients with NPH symptoms and some pictures. However, most of the symptoms are driven by the mimickers, meaning the other disease, such as problem with the back, problem with the knee, or problem with thinking process, dementia, urinary problems. So a lot of these problems are coming from the mimickers. So in these cases, doing a shunt, there's going to be a lot more risk compared to benefit. So in these categories, we do not recommend for VP shunt insertions. Um, so I want to also discuss about how the programming works and how we manage at our center. As I mentioned before, the VP shunt is inserted for these patients at closed position, meaning their valve setting is at 2.5. This is one of the valve machines that we use at our center. Um, the smaller the number, the more water we drain. So we insert at the most conservative setting to minimize any adverse effects. Our team started the initial programming session at 2 month mark after surgery. And we slowly open the valve every 2 to 3 months basis while monitoring improvement in your NPH symptoms and minimizing the potential adverse effects. The main thing they were looking at are subdural hematoma, meaning there is some bleeding in the brain in the particular layer. Most patients require 1 to 2 valve adjustments, occasionally 3, and everything gets done in 2 to 3 months intervals. Once we make the adjustments, we will order CT brain to be completed at exactly between 4 to 5 weeks mark to monitor if there's any subdural hematoma and any other potential adverse effects. This particular bleeding is like a one drop at a type of bleeding. So if I scan your brain way too early, like at 2 to 3 weeks mark, I may not appreciate anything in the imaging. But if I do it around 4 to 5, then I can see if there's any complications there. That's why we try our best to time it. We work closely with the local hospitals for our patients' comfort. The next slide looks very similar, but only changes looking at the valve. So in the first visit, we would move from 2.5 to 2.0 if it's necessary based on our assessment and how patients feel. And if let's say you come in for the second follow-up sessions, then we think we need to open up the valve more, then we'll be moving one setting at a time. So meaning 2.0 to 1.5. And another question that we receive a lot is once we adjust the valve, what do we go based on? And our programming is based on patients' symptoms and our physical assessment. So whenever I see patients from the initial visit to second visit, third visit, based on my chart, I can see the improvements. So that helps us to direct that we're going to the right direction. I would like to also talk about more about nurse practitioner's role at the our center, Howard Cohen NPH program at Toronto Western Hospital. We're getting more popular, so many people more recognize us, but nurse practitioners are the registered nurses in the extended class who have met additional graduate level educations in Canada, mostly master's level. And we also have to have experiences and these exam requirements set by college. Nurse practitioners are authorized to diagnose or to interpret diagnostic tests and prescribe medication and other treatments. In our team, we're part of the interdisciplinary members of our medical team. So I'm under the Division of Neurology, so I report to Dr. Fasano and Dr. David Tangway and also Dr. Dimal that I work closely with. My role particular for the NPH program is that with the supervision of my neurologist, we will complete the initial comprehensive diagnostic assessment, including lumbar puncture, neurological exam, reviewing images, so basically the diagnostic testing that we're doing here. follow appointment care in both movement disorder and cognitive and behavioral neurology clinics, including ordering, reviewing images, prescribing medications, adjusting the valve, triaging medical emergencies, consulting other specialty team at other clinics and hospitals. Often that means that you're going for another surgery at another hospital, or you need an MRI at your local hospital, or you're in the hospital that's close to your home because of other problems. If their team requires some specialty knowledge consultation, our team's there to help navigating those process. And also post-MRI VP shunt valve check, meaning because the shunt is a magnetic device with metal parts in it, it is MRI safe, conditionally safe. Only thing that really requires is what we tell our patients is within 1 week of your MRI, you have to let us know. So we double check the valve setting is not changed by the MRI. Often our patients are great communicating with us ahead of time. So we often put it in the calendar, try our best to get it done as soon as we can. But our recommendation for our patients within 1 week to check. Other than MRI, the valve check, many of our patients who have the valve, there's no other things that they cannot do with their life. So same thing that they were doing before the surgery, they're still able to do so. We are also involved in a lot of quality improvement projects to make things better for our patients and also research. I would like to end the PowerPoint presentation with introducing a little bit more about our team. We're the only interdisciplinary team for NPH program in Ontario. Since 2012, when our program was first founded, we have shunted over 200 patients. Between 2024 to 2025, we shunted about 50 patients. Last year, sorry, the dates are a little bit wrong, but 2024 to 2025, we also did under 50 cases. Interdisciplinary program, meaning that there are different specialists of neurologists and neurosurgeons within the team together. So for movement disorder, it's Dr. Fasano. For memory and cognitive side, the specialty of neurology is Dr. David Tangway, Dr. Nico Dimal, and there's a group of neurosurgeons that we work closely within our hospital. There's another nurse practitioner who is under the division of neurosurgery, my partner, Anna, and also associate scientist, Dr. Gianluca Sorrento, who runs the GATE lab, clinical research coordinator, Sarah, and our administrative staff, Maya, Rita, and Dipti. These are the references here. I would like to also thank Hydrocephalus Canada for the Research Program Award for our new research project that we're running at Toronto Western Hospital for NPH patients, optimizing function for individuals with normal pressure hydrocephalus through individualized and time-sensitive rehabilitation. Thank you.